2 o'clock. Good afternoon. Welcome, everybody. Mabuhay kayong lahat. As a reminder, please mute yourself, but always show your video picture. Sign in your name, FB account, email address in the chat box. Please include the names of your companions, whoever are with you watching and listening to the pep talk. Use the chat box to ask questions and make comments while the pep talk is on. We will have group pictures at the start and end of the pep talk. Please show your face in the video. Another reminder, please take the online learning cum evaluation test exercise or OLETE for mastery of learning and have a perfect score to get a certificate. I have placed the link in the chat box. So let's now have a group picture before we start in 2 minutes. Please turn on your video, show your face. So, okay, also try to take pictures at your end and then send to me good pictures to be included in my file. Okay. Ready? 1, 2, 3. May pahabol. 1, 2, 3. Okay. Excuse me. I'll just save it first. Okay. Okay, my pep talk today is entitled Patient Management Process, focusing on Paraclinical Diagnostic Process. The empowerment objective is for the lay people to have an understanding of the paraclinical diagnostic process in the patient management process. I have a patient management program which I'd like to empower the lay people or patients to take control in the management of their health. I launched this pep talk on May 15, 2021 with a module on COVID-19. After that, I had a second module entitled Patient Empowerment. And now I am on the third module entitled Patient Management Process. What I have in mind in my pep talk, which may run for 3 years, is to empower at least 30 persons with my family members and my patients as a priority. This is my key performance indicator. I hope you will be in this group of 30. This is the patient management process framework. So the module on the patient management process have 6 parts: overview, clinical diagnostic process, paraclinical diagnostic process, selection of treatment process, advice to patients process, peculiarities and limitations of medical practice. We have taken overview and also the clinical diagnostic process before. And today we will be focusing on the paraclinical diagnostic process.
Little.
Okay.
Could you share?
Okay. So, so as I said, we will be focusing on this box, okay, within the patient management framework, the paraclinical diagnostic process. The off point for the paraclinical diagnostic process is the clinical diagnosis. Here, up there, okay, which consists of the primary and secondary clinical diagnosis. After the clinical diagnosis, the next step is to determine whether a paraclinical diagnostic procedure is needed or not. A paraclinical diagnostic procedure is defined as a diagnostic procedure that is done after the clinical diagnosis, which is derived from the signs and symptoms. Okay, so after the clinical diagnosis is arrived at, then that's the time we do the paraclinical diagnostic procedure. Okay? Whether to do it or not is another story. Okay, and its objective is to make the diagnosis more definite. Okay. The foremost indication for a paraclinical diagnostic procedure can be stated this way. If you are not certain on the primary clinical diagnosis and you need to be certain or more certain before the treatment, then go for a paraclinical diagnostic procedure. To decide on the indication for the paraclinical diagnostic procedure, the physician uses two processes. One is the degree of certainty on the primary clinical diagnosis, and two, comparison of the treatment plans for the primary and secondary clinical diagnosis. A physician should consider the following factors. Number one, how certain he is with the clinical diagnosis. And two, whether a more definite diagnosis is needed or not for one reason or another. On how certain he is with the clinical diagnosis, the general rules are, if he is quite certain or very certain, in general, a paraclinical diagnostic procedure is not needed. The quite certain clinical diagnosis becomes automatically the pre-treatment diagnosis. If he is not quite certain or uncertain, in general, a paraclinical diagnostic procedure is needed. In general, a clinical diagnosis is said to be quite certain if it is based primarily on the signs. So signs are those gotten by the physicians that are reinforced by the symptoms. These are those feelings and observation from the patients, and also on the prevalence data. A clinical diagnosis is said to be uncertain if it is based primarily on the symptoms and or on the prevalence data. On whether a more definite diagnosis is needed or not for some reasons or another, example will be if the contemplated treatment procedure is very extensive, mutilating, and risky, okay, then a more definite diagnosis is needed. If the treatment for the secondary clinical diagnosis is the same as that for the primary clinical diagnosis, then a paraclinical diagnostic procedure may not be needed. If it is different, or if they are different, then a more definite diagnosis is indicated. Illustration 1. Certainty of the primary clinical diagnosis. If the degree of certainty is about 60 to less than 90%, which is categorized as not certain, then a paraclinical diagnostic procedure is needed. If the degree of certainty is 90 to 99, then as a rule, it's not needed anymore. The treatment plans for the primary and secondary diagnosis, if they are different, as a rule, they are needed. Okay? If they are the same, not needed anymore. Illustration 2. 98% degree certainty for the primary, 1 to 2% for the secondary diagnosis, and then the treatment plan for the first primary is surgical, and then the treatment plan for the secondary is non-surgical. So the question is a paraclinical diagnostic procedure needed or not? So the answer is no, because of the high degree of certainty for the primary clinical diagnosis, even though the treatment plans will be different for both. Another illustration, 60% for the primary clinical diagnosis, 40% for the secondary. Treatment plan is surgical for the primary and non-surgical for the secondary. So a paraclinical diagnostic procedure is certainly needed because one of the uncertainty of the diagnosis, and two, the treatment plans are different. Another illustration, 60% for the primary, 40% for the secondary, but the treatment plans are the same. Surgical excision, whether it's primary or secondary clinical diagnosis. So the answer is no, because the treatment plans will be the same. Another illustration, 90% for primary clinical diagnosis and 10% for the secondary, but the plan for treatment for the primary is a mutilating operation. So is there a need for a paraclinical diagnostic procedure? Okay, as a rule, you need one because you have to go, you want to be more definite because you're going to do a very extensive operation. You can probably try to bring it up to 98, 99% degree of certainty before you institute the mutilating operation. Another illustration, 70% for the primary, 30% for the secondary. So 70% is under uncertain, and then the treatment plan for the primary is chemotherapy. For the treatment plan for the secondary, it's radiotherapy, so different. So the answer is yes, you need a paraclinical diagnostic procedure. So here is a tickler. Okay. Which of the following statements is the strongest indication for a paraclinical diagnostic procedure? A, you can never be absolutely certain of your clinical diagnosis. Is this a good indication for doing a paraclinical diagnostic procedure? B, you want to confirm a clinical diagnosis of which you are certain of. C, you want to document, to put it on record, a clinical diagnosis which you are certain of. Okay. And D, when you are not certain of your clinical diagnosis. So what is the best answer here? D, as in dog, when you are not certain of your clinical diagnosis is the best answer. After determining whether a paraclinical diagnostic procedure is needed or not, a physician advises the patient on this by explaining the processes that he uses and the outcome of his analysis. He recommends, waits and answers queries from the patient, allows the patient to decide, and forges a shared agreement. So this explanation here is found on this box, advice. Okay. If there is a need for a paraclinical diagnostic procedure, we're now on the selection. We are done with the indication. We're now on the selection. So if there's a need for a paraclinical diagnostic procedure, the physician uses the BRCA processes. B stands for benefit, R, risk, C, cost, A, availability. The physician gives or lists the various options of the paraclinical diagnostic procedure and then gives the data on the BRCA. With the data given, the patient is asked what he prefers. So this is an example of a table that tabulates, compares, and analyzes all the options and the BRCA data. Okay.
Salamat.
So the physician will have to give the data here. Okay. Illustration 1 for the selection. Okay. Most direct for option 1. Okay, in terms of benefit. Okay, so the goal here when you talk about benefit of paraclinical diagnosis is that you want to be more definite on the diagnosis. Okay, so for option 1, you get the most direct results, okay, outcome. Then option 2, indirect. Okay, these for the 3 are acceptable. Okay, and then the cost, they differ from 1,000 to 1,005. Okay, then let's say all are readily available. Okay, so which is the most cost-effective procedure? I suppose because it's option 1 is the most direct and it costs 1,000 pesos. So I don't think you will choose option 3 because even though it's the same 1,000, but the benefit is that it's not very direct, most direct, it's indirect. Okay. Another illustration, the yield for the information or the data from option 1 paraclinical diagnostic procedure is more than 90%. For option 2, 90%. Then option 3, 80%. Okay. All have acceptable risk. And then the prices are 4,000 for option 1 and 2, and then 3,000 for option 3. And all are available. So which is the most cost-effective procedure? Putting priority on the benefit, okay? Always put priority on the 4 BRCA, put priority on the benefit, then risk, then cost availability. So that's the order of analysis, okay? So putting priority on the benefit with more than 50%. So this is the best option, okay? And the cost is 4,000, it's the same as the one for the option 2. Okay. So the best option, the most cost-effective procedure here is option 1. Okay. So at this point, again, after the selection, okay, you have the box here, advice. So at this point, the physician should be explaining the processes of selection, the BRCA, to choose the most cost-effective paraclinical diagnostic procedure and to the desire of the patient. Note I mentioned that we asked the patient what does he want. Okay. Okay. So that is meant by to the desire of the patient. Of course, the patient will be guided by the physician. Okay. So the physician can recommend, he awaits and answers queries from the patient, allows the patient to decide, and then forges a shared agreement. Shared agreement between the physician and the patient. Once a shared agreement is arrived at, an informed consent or informed refusal is formalized. Okay. If there is an informed refusal, the patient does not want this or that, okay, a paraclinical diagnostic procedure is not executed. If there is an informed consent, a paraclinical diagnostic procedure is executed. But just before and during the procedure and right after, the physician advises the patient on the preparation, possible outcome, things to monitor, etc. Assuming that a paraclinical diagnostic procedure is done, so we are now on the interpretation level, on the step. The physician now has to interpret the results of the paraclinical diagnostic procedure. To do this, he uses 2 processes. One is assessment of the accuracy of the report, and 2, correlation with the clinical findings. If he finds nothing unusual in the reporting of the result, he goes on correlating the result of the paraclinical diagnostic procedure with the signs and symptoms of the patient to come out with a pre-treatment diagnosis or a diagnosis just before the treatment. Okay. If the result of the paraclinical diagnostic procedure is congruent with the primary or the secondary, okay, then you can decide to accept. Okay. If it is not congruent with either one, he has to make a decision to accept or to put on hold. This is a tickler again. Determine which paraclinical diagnosis should be accepted as the pre-treatment diagnosis and which one should be put on hold for further decision making. Okay, write A for accept and H for hold. Paraclinical diagnosis is the same as the primary clinical diagnosis. So the recommendation or the decision should be to accept by the physician or even by the patient. If the paraclinical diagnosis is the same as the secondary, then accept also. Okay. If the paraclinical diagnosis is a clinical diagnosis that is least considered out of the blue, okay, so rare, no, then the physician can decide to put it on hold. Okay. And if the paraclinical diagnosis does not jive with the clinical picture or the diagnosis based on the signs and symptoms, then he decides to put it on hold. So after the interpretation, you can see this box again, advice. Okay. At this point, the physician advises the patient on his interpretation and proceeds to the discussion of the treatment. Okay. I will end this pep talk at this point because the focus will be on the paraclinical diagnostic process, and I will discuss the subsequent steps in the patient management process in other sessions. Okay. Okay. Takeaway in this pep talk related to patient empowerment. Okay. At this point of the pep talk, understand the patient management process framework in terms of what the physicians are doing and should be doing in the paraclinical diagnostic process. Be ready to ask questions based on the requirements of the processes, particularly when a physician is not using the processes and is not clear or full, complete in explanation. Participate actively and fully in the problem solving and decision making of your health concerns with your physicians in coming out with the most cost-effective paraclinical diagnostic procedure and to your desire. And then master the paraclinical diagnostic processes as they may help you in some way in deciding on your own health concern whether there is a need for a paraclinical diagnostic procedure, and if yes, how to choose the most cost-effective ones and to your desire. This is one other way of gaining greater control in your health concerns and issues. Remember, our goal is patient empowerment. I'd like to end this talk, but I have decided last night to include an illustration for better understanding of the clinical diagnostic process. So I will give an illustration and present some application of the paraclinical diagnostic processes using patients with breast concerns, pain, patients with breast concerns on pain and mass. Okay. So next time I will talk on other topics like thyroid, etc. But for today, I just choose on one particular organ of concern, which is the breast. Okay. Anyway, most of you are females in the audience. Okay. So example, one scenario. Young female patient with breast pain, but with no palpable dominant breast mass, no lymph nodes, palpable lymph nodes on the armpit, with no signs of inflammation. Okay. So the primary clinical diagnosis given is fibrocystic changes with a 99 degrees certainty or 99% certainty. And secondary clinical diagnosis, breast cancer, 1%. Okay. So the question, is there a need for a paraclinical diagnostic procedure? We're now talking about the indication. Okay. So the answer is there is no need for paraclinical diagnostic procedure like ultrasound, mammography, because of the high degree of certainty of fibrocystic changes. Okay. So what the physician can just advise is just observation and monitoring. Older female patient with the same complaint, breast pain, but no palpable dominant breast mass, no armpit lymph nodes with no signs of inflammation. The primary clinical diagnosis is still fibrocystic changes, but the physician lowers his degree of certainty to 98 because of the age of the patient, because in older patient, there's a higher risk for breast cancer. So he increases the percentage for breast cancer to 2%. Question, is there a need for paraclinical diagnostic procedure? The answer is no need because of the high degree of certainty of fibrocystic changes. Another patient, female, regardless of age, with concerns of a breast mass. Okay, this time breast mass. So examined by a physician with uncertain findings of whether a dominant mass is present or not. Okay, so remember, it's not all the time that when the physician palpates the breast of a patient, he is very certain that there is a breast mass. There are times in which he cannot be certain. So these are the situations. This is an example of the situation. Okay, so since he's not certain, he said probably he just make a estimate. Okay, breast mass present, only 60% probability. Primary, secondary clinical diagnosis, if it's present, the other one should be not present, it's 40%. So because of the uncertain palpation findings of the physician, okay, he will need a paraclinical diagnostic procedure. Okay. So once he said that he needs a paraclinical diagnostic procedure, so we now go to the next step, which is selection. Okay. So in the selection, the physician lists down the options: ultrasound, mammography. Okay. So tabulation of the benefits data, the yield of the ultrasound for this particular patient, the breast mass, okay, is more than 90% for ultrasound. For mammography, the yield is less than 90% in terms of information. In terms of risk, ultrasound practically painless, okay? But for mammography, you have the radiation and the pain, okay? Squeezing the breast between two plates during the procedure, okay? The cost, let's say example, will be 1,000 for the ultrasound and 3,000 for the mammography. In terms of availability, ultrasound is readily available, and then mammography can also be available. Okay. So, what is the most cost-effective paraclinical diagnostic procedure? Okay. Ultrasound. Okay, because as I said, put more emphasis on the benefit. It has the greatest yield, and the cost is less than 3,000. Okay, and then it's also painless, readily available. Young patient, female, with palpable, dominant 2-centimeter solid breast mass, movable, not fixed, well-defined border, no armpit lymph nodes, with no signs of inflammation, no signs of cancer or malignancy. The primary clinical diagnosis is fibroadenoma, 99%. Secondary clinical diagnosis, breast cancer. No need. So the question is there a need for paraclinical diagnostic procedure? So the answer is no need because of the high degree of certainty of fibroadenoma. Another patient, this time older patient, with a palpable dominant 2-centimeter solid breast mass, movable, but the border is not so well defined, ill-defined, okay, which could be a sign of possible malignancy, no armpit and the lymph nodes, still no signs of inflammation. The primary clinical diagnosis, because of this ill-defined border, should be breast cancer, but the degree of certainty put by the physician is only 80%. Okay. And then the secondary clinical diagnosis, it's a benign one, it's not cancer, 20%. Okay. So is there a need for a paraclinical diagnostic procedure? Yes, the answer is yes, because of the uncertainty in the primary clinical diagnosis. It's only 80%. Okay. So going for the selection, okay, options, ultrasound, mammography, needle biopsy, okay. The benefits, okay, I mentioned this already earlier, but we just add a new one. Needle biopsy is one of the consideration. The yield of needle biopsy is more than 90 to 98%, okay. So practically painless for ultrasound, radiation, and pain for mammography, pain, hematoma, infection for the needle biopsy, and then the cost is 10,000 pesos for the needle biopsy, okay. So which should you choose? Okay. So which do you prefer? Okay, so you have options. As I said, this has to be explained to you and then you choose. Okay, you can opt for needle biopsy if you put a lot of emphasis on this goal. Now, but if you are afraid of the pain, if you want to be to say that I want to do it to do the ultrasound first, okay, because it has a yield of 90%. So you can choose either one of these two. Okay. Another patient, older female patients with palpable dominant 3 centimeters solid breast mass, okay, fixed, ill-defined with armpit lymph nodes. So these are signs suggestive of malignancy. Okay, in the earlier example, you have only one sign of malignancy, but here you have already 3: fixed, ill-defined border, armpit lymph nodes. So the primary clinical diagnosis is higher now, 95%. Okay, and then this secondary clinical diagnosis, not breast cancer, 5%. So do you need a paraclinical diagnostic procedure? Okay. So you may need a paraclinical diagnostic procedure because of a mutilating operation, even though you're 95% certain already, okay, that is being planned, and other reasons as probably you don't like to have, the patient does not want to undergo an operation, he wants to undergo chemotherapy and other treatment, okay? Okay. So if there is a need for a paraclinical diagnostic procedure for this patient, okay, so the selection using the same table, okay, so this time probably what will be chosen is number 3 already. If you want to be more definite about the diagnosis, because the yield is more than 90% to 98%. Now, examples of report of accuracy of assessment and interpretation of reports of paraclinical diagnostic procedures. I'll give examples now. Okay. Example number 1 on the assessment of the accuracy of reports of paraclinical diagnostic procedure. Let's just use the ultrasound as an example. Okay. So this one is a 48-year-old female, okay, who consulted me. This is an actual patient. Okay. So my primary clinical diagnosis is breast fibrocystic changes. But the patient decided to have a periodic ultrasound. Okay. So the breast ultrasound done on October 28, 2020 showed BIRADS 4 suspicious for cancer. Okay. So this is the report, actual report. Okay. Solid regular nodule, 12:1 position on the left breast. Tissue correlation is recommended, meaning a biopsy is recommended. Okay. Because of the BIRADS 4. I held on, okay, to my primary clinical diagnosis of fibrocystic changes because of my physical examination findings. Okay, I was not able to palpate a dominant mass. Okay, so I asked for a repeat ultrasound in another institution. Okay, so October 28 was the first ultrasound. The second ultrasound was done on November 16. Okay, 2 weeks after. So it shows BIRADS 1 negative. Okay, so the patient was not yet convinced. He wants to be more assured. So she had herself examined again at a repeat ultrasound. This time it showed virus 3 is still benign, probably benign. Okay. So in contrast to the first reading, which was virus 4 suspicious for malignancy. So my interpretation after analysis of the accuracy of the report is still, I stick to my diagnosis of fibrocystic changes, breast, and not cancer. Okay. Thus, I have avoided an unnecessary biopsy procedure for this patient. Example of interpretation of report of paraclinical diagnostic procedure, again using the ultrasound. Okay. So this is an actual patient also. Okay. So report, the ultrasonographer, okay, made a report bilateral breast masses without specifying as to the specific types, whether cancer or not. Okay. So these are alarming terms, okay, to any layman. Okay. And they are not very specific. Okay. So I after examining the patient and then correlated with the clinical, the paraclinical diagnostic procedure and the clinical findings, I made a commitment that it's the diagnosis is still fibrocystic changes. Okay, it's just a hormonal changes. It's not cancer. Okay, so my diagnosis is more specific and then more reassuring. And the basis for the fibrocystic changes is that you have cyst, which is represented by the cystic term here in that word, and then the masses here, the hypoechoic masses are the fibrous part. Okay. So this is an example of how to interpret the report of the paraclinical diagnostic procedure for the patient. Okay. So I end my PEP talk with this illustration and application of paraclinical diagnostic processes. Okay. And then I hope I have empowered you to have a better understanding of the paraclinical diagnostic process in the patient management process. Okay. So before we go to the open forum and question and answer interaction, just a reminder again, take the online learning cum evaluation test exercise for mastery of learning and have a perfect score to get the certificate. So I have placed the link in the chat box. So let's now have a group picture taking before we start the QA, question and answer, and interaction. Please turn on your video and show your face now. Okay. 1, 2, 1, 2. Wala nang gagalaw. 1, 2, 1, 2, 3. Ay, nawala.